we need physiology-based CTG interpretation. Cardiotocograph or CTG was introduced into clinical practice in the late 1960s. The aim was to timely recognize intrapartum hypoxic stress so that we could avoid hypoxic ischemic encephalopathy and cerebral palsy and perinatal deaths, while at the same time to avoid unnecessary operative interventions both to the mother as well as to the fetus. Various classification systems were introduced which classified CTG traces into normal, suspicious or pathological, or normal, intermediary or abnormal, or CAT1, CAT2 or CAT3. But the problem was most of these classification systems relied on pattern recognition, and therefore they were associated with 30% inter-observer as well as intra-observer variability. In other words, if the same CTG trace was seen by 3 obstetricians or midwife, they are likely to give 3 different answers. And because the CTG is relying on pattern recognition, it leads to significant misinterpretation. Scientific studies have shown that even experts on CTG interpretation, they change their interpretation once they are aware of the fetal outcome. In other words, pattern recognition leads to poor CTG interpretation. In 1971, Prof. Richard Beard was able to show that despite obstetricians of that time panicking while seeing various patterns on the CTG trace and performing emergency cesarean sections with a presumption that the fetus was compromised and was severely hypoxic, Prof. Richard Beard was able to show that even if the CTG trace was pathological and showed late decelerations, the false positive rate was 60%. In other words, if we do 100 cesarean sections for a pathological CTG trace, 60% of the fetuses were non-hypoxic and non-acidotic. But the problem was, in 1970s, due to poor understanding of intrapartum hypoxia and lack of scientific studies, it was thought that fetuses would get hypoxic injury if the pH fell below 7.25. That was because everything was compared with adult physiology. Current scientific evidence has shown that unless the pH fell below 7 and the base excess is over minus 12 millimoles per liter, the risks of cerebral palsy was extremely low. And therefore, according to current scientific evidence, the false positive test of a pathological CTG trace could be up to 70% to 90%. This means if one relies on pattern recognition and performs operative vaginal deliveries due to pathological CTG traces, there is a 90% chance that this operative intervention may be unnecessary. Even additional tests of fetal blood well-being, such as fetal blood sampling, have been shown by systematic reviews to be useless in avoiding unnecessary cesarean sections. It is then not surprising that the latest Cochrane review, published in February 2017, has concluded that compared with intermittent auscultation, CTG monitoring does not reduce the cesarean section rate, instrumental vaginal births, nor does it improve any neonatal outcomes. The Cochrane review also has suggested that access to fetal blood sampling did not appear to influence any differences in neonatal convulsions or other outcomes. It is not surprising that when inter and intra-observer variability of 30% are associated with CTG interpretation, the fourth confidential inquiries into stillbirths and deaths in infancy report, which looked at intrapartum related deaths in 1997, concluded that 50% of intrapartum related deaths were avoidable, and they were mainly due to lack of knowledge to interpret CTG traces, failure to incorporate clinical picture such as meconium, chorioamnionitis, etc., delay in intervention, and communication and common sense issues. The study of stillbirths by the NHS Litigation Authority, which was published in 2009, concluded that 34% of 100 stillbirths, that is third of all stillbirths, were due to CTG misinterpretation. The 10 years of maternity claims published by the NHS Litigation Authority also concluded that CTG interpretation contributed to significant amount of litigation in maternity services, and this amounted to approximately £3.7 billion. The main problem of CTG interpretation was lack of understanding about fetal physiology. The initial guidelines made obstetricians and midwives to panic by calling the decelerations as type 1 and type 2. The bodies got further confused when they saw further decelerations and then classified the CTG traces and decelerations as early, variable, late. When the confusion deepened, the variable decelerations were further classified into typical and atypical variable decelerations. The NICE guidelines of 2014 further confused the picture by classifying the variable decelerations into reassuring variable and non-reassuring variable decelerations. This just illustrates the amount of confusion that is present amongst obstetricians and midwives with regard to CTG interpretation due to a lack of understanding of deep physiological knowledge of the fetus. Every guideline that has been published in the UK led to more and more confusion. This is the RCOG NICE guideline of 2001, which was further complicated by the NICE guidelines of 2007, and the NICE guidelines of 2014 was so confusing that it was withdrawn within 2 years after publication for an urgent review. And this is the current NICE guidelines, and to use this guideline at 2 in the morning is very difficult because it is very crowded and very confusing. It is not surprising then that the latest RCOG report on each baby counts published in June 2007 has concluded that there were 1,136 babies who were damaged or died during 2015, just in 1 year, out of which 126 babies had intrapartum stillbirth, 156 babies had early neonatal deaths, and 854 babies, unfortunately, had severe brain damage. It is notable that the report has concluded that in up to 76% of the cases where sufficient information was available, substandard care may have contributed to the poor outcome, and different care may have resulted in different outcome. When we did pre and post tests in 15 centers in the UK and tested 810 midwives and obstetricians, we were able to show that at the pre-test, at the beginning of the course, before the transfer of knowledge on fetal physiology, only 25.1% of midwives and 30.1% of obstetricians correctly answered questions, and this is quite worrying. Operative interventions due to CTG misinterpretation also leads to poor outcomes. Both mothers and babies have complications. Every cesarean section increases the risks of subsequent placenta accreta, increta, and percreta. The problems of CTG interpretation and misinterpretation is not unique to the UK. Even studies from other countries have concluded that substandard care is common in birth asphyxia and human error is the cause in most cases. So when we look at CTGs, the first issue is hypoxia the cause of the observed CTG changes? Because human labor is a very complex process. Mechanical compression of the fetal head, umbilical cord, a simple vaginal examination, increase in the temperature of the mother can all cause CTG traces. Similarly, drugs which are administered during labor also may cause CTG changes. The second issue is to understand the type of intrapartum hypoxia that the fetus is exposed to based on the features observed on the CTG trace. It is also very important to understand the fetal reserve because one guideline cannot be applied to all babies in labor. A fetus who is growth restricted does not simply have 50% of contractions having decelerations to avoid hypoxic damage, as stipulated by the guidelines. Individualization of care based on fetal physiology and pathophysiology is very vital. Fetuses who are exposed to hypoxic or mechanical stresses during labor, they do compensate well. They do have inherent compensatory mechanisms. But one must be very careful and understand and appreciate that both prematurity and post-maturity can affect these compensations. Similarly, a fetus gets affected by the rapidity of onset of hypoxia and the duration of hypoxia. So the same CTG trace in a fetus whose mother is a primip, who is stuck at 3 centimeters, is totally different to another fetus whose mother is a multip and has progressed up to 8 centimeters spontaneously. Because the first fetus has another 7 to 8 hours of labor to accomplish delivery, whereas the second fetus needs to go through labor and the hypoxic stress for only 2 more hours. Similarly, the effect of meconium and temperature and inflammation can also affect fetal well-being, and therefore these factors need to be considered whilst interpreting CTG traces. Human factors such as inability to understand fetal physiology, failures in communication, delays in action, as well as additional birth trauma on top of ongoing fetal hypoxia can also result in CTG misinterpretation and poor neonatal outcomes. So when one reads a CTG trace, one needs to take a step back and look at the cause of the observed CTG traces. Is it hypoxia or is it something else? Then one needs to understand the type of intrapartum hypoxia, the reserve of the individual fetus in question, the fetal compensatory mechanisms that are in place to determine whether the observed changes on the CTG reflect fetal compensation or decompensation. At the same time, an obstetrician or midwife has to consider the wider clinical picture whilst interpreting CTG traces. This is definitely a pathological CTG trace by any guideline in the world if it persists for more than 30 minutes. But as obstetricians and midwives, we need to apply fetal physiology to determine whether, whilst this fetus is stressed, is the fetus compensating to the ongoing intrauterine stress. Secondly, we need to determine whether the fetus is depending on additional resources to compensate, or if there is any evidence of decompensation. In the presence of features on the CTG trace which are suggestive of fetal decompensation, the answer is not to perform an emergency cesarean section or to cut the fetal scalp to look for peripheral acidosis. But one needs to identify the cause of the fetal hypoxic stress so that corrective action could be taken to remove the stress if possible, or to perform intrauterine resuscitation by administration of fluids if necessary, and tocolytics and changes in maternal position to improve the intrauterine environment. One should not test a peripheral tissue, which is the skin, which is also squashed in labor with caput and molding and surrounded by alkaline amniotic fluid, because it may give false sense of reassurance in the presence of contamination with alkaline amniotic fluid. So we need to take our head out of the sand and move away from pattern recognition, which results in insignificant inter and intra-observer variability in CTG misinterpretation, leading to missing the babies who are exposed to hypoxic stress, at the same time increasing the risk of unnecessary operative interventions to the mothers. We need to prospectively predict the changes on the CTG trace based on fetal physiology. Let's avoid mothers and fathers experiencing sadness due to losing their babies due to secondary to CTG misinterpretation. Let's understand the physiology behind CTG patterns so that we could identify a fetus who is exposed to stress and is undergoing decompensation so that corrective action could be taken to avoid intrapartum hypoxic injury. Thank you.